Right, so we're going to talk about the patient with anemia. Um, this is just kind of a review of anemia in general because, you know, there's that whole umbrella basically of anemia. So then we break down our cause, but we really haven't talked about anemia. So I wanted to start this video out talking about like anemia in general, um, just because I haven't talked about it in any of these videos so far. So anemia is basically just that abnormally low number of circulating red blood cells, um, a low hemoglobin concentration, or it could be both. The most common cause, though, is the decrease in the number of circulating red blood cells. So this can either be caused by a decreased red blood cell production or an increased red blood cell loss or an increased red blood cell destruction. I'm sure that you guys are probably very much aware that there are numerous different forms of anemia. And so we're really going to focus on the iron deficiency, the vitamin B12, the folic acid, and then we'll also focus on sickle cell anemia, which is sickle cell disease, and aplastic anemia. And we'll kind of keep it simple, and we won't go too into detail about any of those others. When we think about the general pathophysiology of anemia, we have to think about the fact that every type of anemia will reduce the oxygen carrying capacity of the blood, which leads to tissue hypoxia. So think about what hypoxia looks like in your patients, and then depending on how severe that hypoxia is, uh, you might get different manifestations. If you have a very slow onset of anemia, then your body has already compensated because our body loves that whole idea of homeostasis. So our body in those slow situations, in that chronic anemia, will have changes that will compensate, and so that will change the way that you manifest with chronic anemia. Now, if it's an acute development of anemia, then your body doesn't have that chance to compensate, and the manifestations are going to be completely different. Chronic anemia can be caused by blood loss, so this would be not acute blood loss, but that GI bleed, or a nutrient deficiency anemia. Patients will uh, most likely be asymptomatic until the need for oxygen exceeds oxygen availability. So, if they are experiencing some form of stress, or maybe they decide to vacation in Colorado and all of a sudden they are now in this lower oxygen environment, and so now that anemia is going to be a little more obvious. So if this is caused by chronic bleeding, your body has a difficult time producing new red blood cells because the iron stores are depleted. So how do you think those iron stores became depleted? I want you to think about that as you are kind of reviewing anemia in general for the test. Why would your iron stores become depleted with this chronic bleeding? Is it because your body is compensating? I'm going to go over the chronic anemia manifestations, and then from this point on, you will just see chronic anemia manifestations. So, pallor of the skin. The patient's pale, their nail beds and mucous membranes are pale. Uh, Heart and respiratory rates rise. This is because your heart is attempting to increase the cardiac output because the demand for oxygen is so high that we are trying to pump that blood everywhere that it's needed as quickly as possible. We're also breathing faster because we have to provide oxygen to the blood that our heart is pumping so much faster. So then your uh, tissue hypoxia can cause angina, fatigue, dyspnea, and usually this dyspnea will occur on exertion. So just kind of walking around a little bit will cause these patients to get really short of breath. And then these patients will have a headache, dizziness, and dim vision. The dim vision is related to cerebral hypoxia. When you think about headache and dizziness, um, this can be related to the cerebral hypoxia also, but also think about if someone is hypotensive. Why would someone be hypotensive with anemia? Because they don't have blood. And then bone pain. So this is caused because there's an increase in the release of erythropoietin, which will stimulate the bone marrow. So that's where these patients get that bone pain. With acute blood loss anemia, your blood volume decreases much faster, but that decrease in oxygen carrying capacity of blood to compensate for a decrease in blood volume results in an increase in your heart rate, and your blood vessels will constrict. So you'll have tachycardia, pale, cool, clammy skin, tachypnea, uh, because we're trying to fix that hypoxemia. Signs of circulatory shock may occur if blood loss continues. So this would present in hypotension, tachycardia, decreased level of consciousness, and oliguria, because now the blood loss is becoming so great that we are trying our best, but we're not even perfusing uh, blood to our kidneys, so we're not making urine. So we are actually going to discuss B12 deficient anemia and folic acid deficient anemia in the rest of this video. So with iron deficiency anemia, we have iron stores that are depleted, resulting in a decreased supply of iron for the manufacture of hemoglobin in the red blood cells. Commonly results from blood loss, uh, increased metabolic demands, syndromes of gastrointestinal malabsorption, and dietary inadequacy. And then also, according to your Icky book, chronic alcoholism will play into this, or folic acid anemia. So as far as assessments, we are going to be looking for those signs and symptoms of chronic anemia. So your pallor, weakness, fatigue, that low hemoglobin and hematocrit level, and then red blood cells that are microcytic and hypochromic. Manifestations also are going to include brittle, spoon-shaped nails, and then pica, so a craving for unusual substances. And then a lot of time, whenever someone has pica, they are craving ice. If the iron increase in your diet is not going to be enough for the patient, then you're going to encourage them to take iron supplements. So then when we're teaching them to take these iron supplements, we're going to want to tell them, hey, you need to take this in between your meals uh, for your maximum absorption. And make sure you take that with fruit juice, fruit juice, which is high in vitamin C. So this will increase your absorption. So an orange juice or tomato juice. And then um, don't take that when you are going to be drinking some milk or if you're going to take antacids because that's going to decrease the absorption of these iron supplements. And then maybe your patient is going to be a patient that is going to have iron replacement IV. So my wife had to have this done when she was pregnant with our third child. She got severe anemia related to, I think it was just malabsorption across the board. I think the baby was just taking everything away from her. So they made her go in and get IV administrations uh, of iron sucrose. And so when she was getting this, not only did she have to get it, I think twice a week she went in and got these administrations of this iron, but she would have to stay for an hour after administration to make sure that she didn't have an anaphylactic reaction or any type of reaction whatsoever. So just think about those patients too when they're taking the iron. And then maybe you have a patient that doesn't tolerate pills. You're going to encourage them to, if they're taking the iron elixir, to use a straw because this is going to stain their teeth. A last couple of thoughts as far as nursing interventions when caring for this patient. When you're educating about those oral supplements of iron, you'll want to mention that the stools could be black or really dark green in color. And then also, if you're taking care of a patient who is anemic, and this is across the board for your anemia patients, and they're weak and they're fatigued, then you're really going to want to focus on making sure that that patient is safe and understands that they are at a risk for falls no matter how good they're feeling at any given moment. So I like this handout because it is a really good handout that you would actually be able to hand to your patients to kind of let them see, hey, this is what iron deficiency anemia looks like, and this is what you have. So when you think about certain causes that kind of hit particular groups, women who have um, just this extreme bleeding and menstrual blood loss and then your patients with a GI bleed are going to make up probably the bulk of your iron deficient anemia patients. Um, so I really like this handout because it kind of lets the patient know what to expect with what they've got going on. It covers the oral iron supplements, increasing your oral iron intake through diet if possible, and then what intravenous iron administration would look like. So with vitamin B12 deficient anemia, your red blood cells are going to be macrocytic, which will result in a high MCV on your uh, CBC. And then they will also be misshapen, so they're oval instead of concave, and they are fragile and have a shortened lifespan. So if you remember in class, I made a mind map for this. If this works for you, I would suggest doing that for this, to help separate the anemias. But as far as your causes for B12 deficient anemia, you have either that inadequate intake of your B12, so your diet is not rich with B12. It could be because you're vegetarian. Um, it could be a poor absorption of B12 from your GI tract, or it could be a lack of intrinsic factor, which causes absence of absorption. So you don't even absorb at all, which would mean that you have pernicious anemia. One important thing to think about with vitamin B12 anemia is that with your signs and symptoms, you're going to have uh, if you have pernicious anemia, you're going to have that sore, beefy red tongue, and diarrhea. But then overall with B12 anemia, you have neurosymptoms. So paresthesia in your limbs, in your extremities. Uh, this could progress to spinal cord damage. And then the bad thing about this is if you don't treat this early enough, the damage could actually be permanent. And so the way that we diagnose pernicious anemia is through a Schilling's test. So if your Schilling's test is positive, then you have pernicious anemia. And the way the Schilling test works is, I think Michael did a great job of explaining that in the video. So they give you B12 uh, and they measure your B12, and then they give you B12 again, and they give you the intrinsic factor and they measure. And so there's actually 4 stages to this, and you don't have to like get too complex with this. Just if you understand that the way this works is that they are measuring your B12 level before and after they administer this intrinsic factor. Uh, that is how they differentiate. So if you do have pernicious anemia, then simply improving your diet or taking that B12 supplement is not going to work to give you B12. So you'll have to take lifelong injections of the intrinsic factor. Folic acid anemia is very similar to B12 anemia, so a lot of times students will have trouble separating these two. So naturally, I put them together in the same video because that's going to help you guys even more. But so folic acid is actually B9, um, and here the red blood cells are fragile. They're more immature, and then They're megaloblastic, and then they are megaloblastic. So you'll have a high MCV with this also. When you think about the causes of folic acid anemia, this occurs in older adults, and then people with alcoholism or drug addictions, TPN recipients. So your TPN recipients, you'll see them get folic acid a lot in addition to the TPN. And then increased metabolic requirements of pregnancy. So my wife became severely anemic when she was pregnant with our last child, and I had to give her B12 injections, and she also had to take folic acid, and she was also getting iron uh, sucrose at um, from a hematologist. So alcohol suppresses the folate metabolism. That's why it's more commonly associated with folic acid anemia. But chronic alcoholism can also be associated with iron deficient anemia. If you look at the manifestations, these develop gradually as your folic acid stores are depleted. And so it looks like chronic anemia, but then if you look, you'll have a smooth tongue, some diarrhea, but you don't have neurosymptoms. That's the important thing there. So when you're separating B12 and folic acid, B12 you're going to have those neurosymptoms, folic acid you're not. And then diagnosis. So an HMP, how's that going to help you diagnose this? So it could be that patient that's going to drink just a little bit of vodka with their orange juice in the morning. And then your Schilling's test. So this would help you differentiate if you know that it's not a vitamin B12 deficiency or pernicious anemia. then that would help you kind of figure out, okay, this is probably folic acid deficient anemia. So these patients you will encourage to take uh, folic acid supplements, and then you're also going to encourage the patient to eat foods that are high in folic acid. So when we think about erythropoietin as a medication, this is a medicine we give to people who have chronic anemia to help them battle that and to stimulate that red blood cell production. So this will be administered sub-Q. Usually it's given concurrently with IV iron replacement. When we think about other possible treatments for anemia, blood transfusion is definitely something that could potentially happen. So you want to figure out what your patient's allergies and previous transfusion reactions uh, that they may have had. You want to ask about those reactions. Were they pre-medicated? Sometimes doctors will pre-medicate patients with Tylenol and Benadryl to prevent a transfusion reaction. You also want to cross-match your patient's blood band information with two nurses. You can check your facilities policy just to make sure you know if two nurses to them are two RNs or an LPN and an RN, but it's never going to be a nurse and an aide together. You don't want to warm up your blood before you give it. It will be cool because it has come from the blood bank. Speaking of which, you want to give that within 30 minutes. You want to start that blood within 30 minutes of getting it from the blood bank. And then you don't want to add any meds to your product. You also want to think about that this patient needs to have like an 18 or a 20 gauge in because the bigger that needle, the less damage those red blood cells are going to get as they're going in. And then your severe reactions are most likely to occur within the first 15 minutes or first 50 cc's of your blood. And then you want to make sure that you infuse each of your units over 2 to 4 hours, but no longer than 4 hours. You have to have that complete unit infused within 4 hours of starting it. So when you think about caring for these patients, you want to make sure that you are encouraging that increase in dietary intake. You're going to give them the medications or the transfusions that have been ordered, and you want to make sure that you're giving those at proper times, using proper techniques, and then helping conserve energy. So, how are you going to conserve energy for these patients? We have to care for them, but we also have to try and help help them get better. So one way that you can conserve energy is by grouping care with like your other, like your aide, and maybe physical therapy also happens to be up there. So you guys like work together to try and group your care so that you do everything over like a 30-minute span or an hour with this patient, but then that patient will be left alone because they are very tired. You want to encourage them to rest and then make sure that they're getting adequate sleep. And then also keep an eye on their tolerance to activities. Smoking cessation. Why do you think that's important? Uh, I mean, when you think about patients who are anemic and they're having issues with oxygenation, you will never be able to argue the health benefits to anyone about the benefits that smoking will give you, especially for someone who is anemic. So, aplastic anemia is a deficiency of circulating erythrocytes and all other formed elements of blood, so your platelets and white blood cells, resulting from the arrested development of cells within the bone marrow. It can be primary or secondary. Several possible causes exist, including chronic exposure to myelotoxic agents, viruses, infection, autoimmune disorders, and allergic states. So you will see this a lot, though, um, with chemotherapy. So the definitive diagnosis is determined by bone marrow aspiration, and this will show a conversion of red bone marrow to fatty bone marrow. And then therapeutic management will focus on restoring function to the bone marrow and involves immunosuppressive therapy, and bone marrow transplantation uh, is going to be your treatment of choice if a suitable donor exists, which is not always easy to find for these patients. If the cause is a myelotoxic medication that is being administered for another purpose, the medication may be discontinued to improve bone marrow function. When you think about your assessment, you're going to assess for pantocytopenia. So this is that deficiency of the erythrocytes, leukocytes, and thrombocytes. So when you think about that, what would that look like? So you're going to have your signs and symptoms of that patient who is at risk for bleeding. You are going to have a patient who is at a risk for infection. And then you're going to have a patient that is also going to be weak and very pale. They are going to have the bruises, the petechia, the purpura, uh, and then they're going to be tachycardic. So that's, one of those responses to anemia. And then they are also going to be fatigued. When you think about your interventions, you need to prepare your patient for the possibility of a bone marrow transplant. And then you also need to administer those immunosuppressive medications as prescribed. Anti-lymphocyte globulin or anti-thymocyte globulin may be prescribed to suppress the autoimmune response. And then colony stimulating factors may be prescribed to enhance bone marrow production. Corticosteroids and cyclosporin may be prescribed. And then the potential that you're going to administer blood transfusions if prescribed. So when you do that, you'll want to monitor for signs and symptoms of a reaction. So when we think about caring for this patient, uh, there are definitely a lot of factors to consider. Not only the fact that this patient is anemic and is going to need blood, but then they also have thrombocytopenia. They are also immunocompromised because they have a low white blood cell count. So just think about all the things that you, as the nurse, are going to have to make sure is being done for this patient. They are still allowed to have visitors, but their visitors are probably going to need to wear a mask if their white blood cell count is too low. So um, there is a lot to consider when taking care of these patients. So we're going to talk about sickle cell anemia. This is in a group of diseases that are termed hemoglobinopathies, in which the hemoglobin A is partly or completely replaced by abnormal sickle hemoglobin S. So it is caused by the inheritance of a gene from a structurally abnormal portion of the hemoglobin chain. And the risk factors include having parents heterozygous for hemoglobin S or being of African American descent. For screening purposes, the sickle turbidity test is frequently used because it can be performed on blood from a finger stick. and yields accurate results in 3 minutes. However, if the test result is positive, hemoglobin electrophoresis is necessary to help distinguish between patients with the trait versus if they actually have the disease. Hemoglobin S is sensitive to changes in the oxygen content of the red blood cell. Insufficient oxygen causes the cells to assume a sickle shape, and the cells become rigid and clumped together, obstructing capillary blood flow. The clinical manifestations occur primarily as a result of obstruction caused by sickled red blood cells and increased red blood cell destruction. So when you think about the obstruction, there's this hunger, this starvation for oxygen in these different parts of our body. And so when we think about a lack of oxygen, the body's response to that is this horrible sudden pain. Situations that precipitate sickling include fever, dehydration, and emotional or physical stress. So, any condition that increases the need for oxygen or alters the transport of oxygen can result in sickle cell crisis. So, poor Brittany she was hitting the gym just so much that that stress caused that sickle cell crisis. So there are various forms of what would cause the crisis. We have vaso-occlusive, splenic, hyperhemolytic, and aplastic, sorry. But it's not important what is causing it. What I want to know, what I hope you guys know, is you have someone in crisis. So what are we going to do for that person? So with these people that are in these sickle cell crisis situations, we want to reverse that. So we reverse the underlying cause and give adequate oxygenation and hydration. These patients are approached with an interprofessional approach to care. So the focus here is going to be on prevention. So preventing exposures to infection and maintaining normal hydration, keeping your patients out of these risk for physical or emotional stress that might exacerbate that issue. And then treatment, you're going to focus again on hydration, oxygenation, pain medication, or pain management, not necessarily pain medication, and bed rest during the crisis. And then, as far as interventions, to maintain adequate hydration, we may be using IV fluids, and then we also will be pushing oral fluids on these patients. So, oh look, you finished that jug of water that I just gave to you, so I'm going to go fill this up again and make you drink it again, and just continue to push oral fluids on these patients so that they can replace their electrolytes and they have an adequate hydration, because this will also help control their pain level if they are adequately hydrated. We're also going to administer oxygen and blood transfusions as needed to increase tissue perfusion. We're going to also administer analgesics as prescribed. And then also when we think about pain management, if a decrease in our oxygen level causes an exacerbation, then we are going to have these patients on bed rest during these sickle cell crisis episodes. We're going to encourage them to consume a high-calorie, high-protein diet with folic acid supplementation. And then we're going to administer antibiotics as prescribed to prevent or treat infections. And then we're going to monitor for signs of complications, including increasing anemia, decreased perfusion, and shock. And so that would present in mental status changes, pallor, or your vital sign changes. And then we want to instruct the patient about early signs and symptoms of crisis and the measures to prevent crisis. And then we want to ensure that our patient also receives the pneumococcal and meningococcal vaccines and an annual influenza vaccine because of susceptibility to the infection. And then in some patients, a splenectomy may be necessary if they experience recurrent splenic sequestrations during these crisis events. And then we also want to inform are patients of the hereditary aspects of the disorder. So speaking of hereditary, I do want to kind of talk to you guys about a patient that I cared for that had sickle cell anemia and talk to you about how we treated that patient and what we did to kind of get her through that crisis. She was African American. She had the most beautiful little son, and my heart was breaking for him because I was afraid that he was going to end up having sickle cell anemia too. But I was relieved when I found out that her husband was actually Caucasian and was not a carrier of the sickle cell trait. So this little boy was not going to have sickle cell anemia. But this patient was admitted to the hospital to get hydration and treat an infection. She had pneumonia, and so we were giving her IV antibiotics. But the horrible thing is, she would scream out in the middle of the night um, for what seemed like no reason at all. But, you know, she was going through those situations in her circulatory system where those sickle blood cells, those sickle hemoglobin cells, were blocking circulation to different areas and cutting off oxygen. So she would have this pain in her legs and in her in her abdomen that were related to these blocks in circulation. So the important thing with her was that we wanted to keep her room warm and not cold, because when you think about when you're in a cold room, what happens to your vessels to kind of compensate and react, and so they constrict because that is their reaction to that cold environment. So yeah, we would keep her room warmer, and then we were hydrating her. We were treating her with antibiotics for the pneumonia, and doing our best to manage her pain. But she was on bed rest, and when her family would visit, obviously moms don't get much of a break even when they're in a hospital bed. So this adorable little toddler wanted every second of his mom's attention and wanted her to get up and play with him, and really had a hard time understanding what was going on. So, just kind of think about that patient also when you think about sickle cell. I mean, Brittany was great as a sickle cell patient, but there's another patient for you to think about also. So when we think about the patient with thrombocytopenia, that is a platelet count that's less than 100,000 per mLs of blood. Um, this will lead to abnormal bleeding potentially, especially once you get uh, lower. So if you get to less than 20,000, then you're going to have that spontaneous bleeding and hemorrhage from minor trauma. And then if you are less than 10,000, you're going to have serious, potentially fatal bleeding possible. So that would be like internal bleeding, just this spontaneous cerebral hemorrhage. So this results from three different mechanisms: either decreased production, um, an increased sequestration in the spleen, or an accelerated destruction. So when you think about the types of thrombocytopenia, the two that we're going to focus on are that ITP, so the immune thrombocytopenic purpura, and then the other one that we will focus on is heparin-induced thrombocytopenia. This is the most common drug-induced thrombocytopenia. When you think about secondary causes, think back to aplastic anemia and think about that patient, and then how if there's a bone marrow malignancy or an infection or radiation therapy, drug therapy, so chemotherapy, something like that that could cause thrombocytopenia. So with the ITP, when we think about the pathophysiology, it's an autoimmune disorder that creates accelerated platelet destruction. And I don't know if you guys remember me saying this in class either last semester or this semester. When you see the word autoimmune um, and you think treatment, your mind already should kind of shoot over to steroid. We're probably going to use a steroid. I don't know. We'll have to see when we get to that slide if there's a steroid, but I would almost put money down that there's a steroid to treat this. And then we think about your platelet production with this is going to be normal, but your spleen is going to be the bad guy here. So your spleen's going to recognize this as foreign. So your spleen will start to destroy those platelets, and then usually platelets will be in your body for a good long while, but in this case, your spleen starts to destroy it within 1 to 3 days. So this can be acute or chronic. So if it's acute, um, it will only last for like 1 to 2 months and then it'll resolve. But if it's chronic, uh, this is going to occur in adults age 20 to 50, and then it is usually with other immune associated diseases like lupus or HIV. So when we think about our manifestations, this is caused by that bleeding because you have thrombocytopenia, and this bleeding will occur in small vessels and mucous membranes. So then you will develop that petechia, the purpura, or the ecchymosis. And then you can also have epistaxis, uh, hematuria, excess menstrual bleeding, and bleeding gums. And then in general, you're probably going to be thinking along the lines of, hey, this person's at a risk to bleed. What nursing interventions do you think this person needs? Oh my God, there's oral glucocorticoids. So we're going to use those to treat this because our steroids are going to suppress that autoimmune response. These patients may relapse when this drug therapy is discontinued. So when you think about steroid use and your patient's going to be going off of steroids, one thing that we try to do to keep the body from relapsing or to keep the body from going into some type of shock is we instruct these patients, hey, you're going to have to make sure that you taper your dose on this. So don't just suddenly stop taking this because your body's going to freak out. And then these patients could potentially need a splenectomy, and it is the treatment of choice if relapse occurs after drug therapy is discontinued. Um, so when you think about the patients getting the splenectomy, we're not going to go into crazy detail about that, but just think about what you would have to prepare the patient for, what you would talk to the patient about after that splenectomy. What would your focus be then? And just kind of think about that patient. So with your heparin-induced thrombocytopenia, this is going to be related to either a heparin drip or maybe heparin sub-Q or Lovenox. When you think about what's going on with heparin-induced thrombocytopenia, basically your platelets start to aggregate, which causes thrombosis. So because all of these platelets have formed all of these little thrombosis areas throughout your body, you end up having thrombocytopenia because you don't have platelets remaining in your circulation. So when you think about the manifestations with this, you're bleeding, depending on how early you catch this, you might not have bleeding. So if this is a patient that's on a heparin drip in the hospital setting, maybe just those daily labs are going to kind of catch your attention or the doctor's attention. Hey, these platelets are dropping really fast. Holy smokes, this person's on a heparin drip. You know what? Let's go ahead and DC that heparin drip and stop this right away before it gets too bad. But now, if you have patients that go home on heparin sub-Q injections, or if they go home on Lovenox, then and another name for Lovenox is enoxaparin. But so yeah, if these people go home, that bleeding can get really bad because we're not monitoring their platelets when they're at home. But then also, when you think about manifestations, you have that arterial thrombosis, the venous thrombosis. So you've got a patient that's on a heparin drip. I've had this patient, and all of a sudden, uh, you start to notice that they've got these DVTs, or that maybe their pedal pulses all of a sudden are extremely diminished or non-existent, and it it, it doesn't make sense that somebody is clotting when they're on a heparin drip. So that's going to be a really big alert going off in your head. Hey, something's wrong here. This isn't right. And so the next thing you want to do is double check what was their platelet count this morning. So you've recognized that your patient is in thrombocytopenia related to heparin. So we're in HIT, heparin-induced thrombocytopenia. If you look at the platelets, and they've gone from, let's say they're at the high end of normal, um, and so let's say they go from like 400,000 to 200,000 the first day that this patient is on the heparin drip. And then you look the next morning, and as you're reviewing these labs and watching where this level is going, and you're kind of watching that trend, you notice that it goes from 200,000 to 100,000. So at that moment, if you know that the patient is in heparin-induced thrombocytopenia, as a nurse, do you think that you would call the doctor and wait to see what the doctor has to say about that? Or are you going to go ahead and stop that drip and tell the doctor about it when he decides to call back? Um, if you think about this, it's it's the same concept as if someone is receiving IV antibiotics and they start to have a rash or they start to have an anaphylactic reaction. We're not going to say, sir, I need you to calm down. I've got to call out to the doctor. He's going to call back probably within the next 30 to 40 minutes. And then at that point, I'm going to stop that drip. Um, no, you're probably going to go ahead and stop that piggyback of antibiotics before things get too bad. Same with this. You're going to stop everything heparin related. When you think about nursing care for thrombocytopenia, part of that is just watching those trends of your CBC and recognizing that as it's happening. And so when you've got a patient that's on heparin, it's something you do want to pay attention to because it does happen uh, more commonly than you would realize. And then you also want to monitor for signs of bleeding, and then for signs of those areas of thrombosis throughout the body, and then um, neuro changes, so a headache, an altered mental status, visual changes, or a decreasing level of consciousness with this patient because maybe they've got a intercerebral hemorrhage. And then if you want to review precautions for bleeding, I would recommend just watching the hemophilia video again because um, I'm not gonna make you sit through that discussion again. Alrighty, so our patients with hemophilia. So hemophilia refers to a group of bleeding disorders that result from a deficiency of specific coagulation proteins. Identifying the specific coagulation deficiency is important so that definitive treatment with the specific replacement agent can be implemented. Aggressive replacement therapy is initiated to prevent the chronic crippling effects from joint bleeding. The most common types are factor VIII deficiency, so that would be hemophilia or A or classic hemophilia. This makes up about 80% of your cases. And then factor IX deficiency would be that hemophilia B or Christmas disease. This is going to make up almost that other 20%. And then, of course, we have a couple of other types also, but we'll focus on the hemophilia A and hemophilia B right now. So, when you think about hemophilia, it's transmitted as an X-linked recessive disorder. So, it may also occur as a result of gene mutation. So typically, your carrier is going to be the female that passes on the defect to affected males. So one thing we had talked about, could females get this? So female offspring are rarely born with the disorder, but may be if they inherit an affected gene from their mother and are offspring of a father with hemophilia. This really wouldn't be something that you would see very often or hardly at all. So we kind of hit the lottery when we had these two Snapchat patients. Good for us. But, nursing school, we're full of the X chromosome. The primary treatment is replacement of the missing clotting factor. Additional medications such as agents to relieve pain and corticosteroids may be prescribed depending on the source of bleeding from the disorder. And then, whenever you think about assessing these patients, you're going to assess for abnormal bleeding in response to trauma or surgery. And then sometimes, when you think about that, this is very common in your male patients. Sometimes this is actually recognized really early in those boys when they have a circumcision. So you're not, going to see a patient that would typically come to you in their 20s and not realize that they have hemophilia, unless they've been living under a rock and um, that rock is covered in blood because they've been bleeding. But other things that you would notice is epistaxis, so nosebleeds, joint bleeding causing pain, tenderness, swelling, and limited range of motion, a tendency to bruise easily, and then results of tests that measure platelet function are normal, but the results of tests that measure clotting factor function may be abnormal. So when we talk about the test that is abnormal, that's going to be your PTT. Your PTT is going to be the test that you're going to notice is elevated, and your PT will not be. So one thing I want you guys to think about when we think about these patients that are at a risk for bleeding, if your PTT is elevated, this can be elevated as a result of heparin infusion. So let's say that we have a patient that is bleeding. How are you going to know if that patient is bleeding as a result of hemophilia or if this is bleeding as a result of heparin-induced thrombocytopenia? If you're just looking at the labs, what is going to tell you this is hemophilia or this is thrombocytopenia? Because the PTT is going to be elevated for both. So what else is going to tell us the difference between these? And then when you think about interventions, you're going to monitor for bleeding and you're going to maintain bleeding precautions. So again, when we think about our patients with thrombocytopenia, what do bleeding precautions look like? Same with hemophilia, bleeding precautions. We definitely don't want them brushing their teeth with a hard bristle toothbrush. So we're going to say, hey, make sure you use a soft bristle toothbrush. We want to make sure that they're keeping their oral mucosa moist, that their lips are hydrated so that they're not cracking and bleeding, no forceful nose blowing, and then no straining to have a bowel movement. So, what is something that these patients may need to make sure that they're not going to be straining when they have a bowel movement? I think you guys probably went over this in Pharm a little bit about medications that might help with this. And then we're going to really stress to this patient that they need to apply pressure for an extended amount of time to those sites that are bleeding, and they may need to apply ice. What would ice do when you think about someone who's bleeding? Kind of relates back to that sickle cell patient, and the reason that that cold environment is bad for that sickle cell patient is the opposite for your patients who are bleeding, why you would want them to have ice. It's the same thing that happens, but we're glad that it's happening. So kind of think about that. And then no blade razors, electric use only. So I don't care if it's the Gillette 17 bladed razor that will never cut. You're really going to stress to these patients, hey, you're going to need to use an electric razor for right now and for your whole life because you have hemophilia. This isn't temporary. So just make sure that you're stressing that. And then no rectal thermometers. Other interventions to consider, we're going to prepare to administer factor VIII concentrates, either produced through genetic engineering or derived from pooled plasma as prescribed. Then we're also going to potentially administer DDAVP for these patients, so that's vasopressin. It's a synthetic form of vasopressin, and so we're going to administer this because it increases plasma factor VIII and may be prescribed to treat mild hemophilia. Then we're going to monitor for joint pain, immobilize the affected extremity if joint pain occurs. We immobilize because we don't want to cause the joint to bleed any more than necessary. And then we are also going to be assessing neurological status. So I know we're not into neuro yet, but you know, a lot of times our body systems are going to kind of play off of each other. So when we think about why we're assessing the neurostatus, we don't want this person to have an intracranial hemorrhage. So we are assessing to make sure that they aren't. And then we're going to monitor urine for hematuria. We're going to control joint bleeding by immobilization, elevation, and application of ice. And then we may have to apply pressure for superficial bleeding for up to 15 minutes, maybe longer sometimes with these patients. We are going to instruct the patient and their family about the signs of internal bleeding. Then we'll instruct patients in how to control the bleeding, and we'll instruct patients regarding activities that they can um, potentially have more bleeding with, so contact sports. And then we may also have to assist in developing an appropriate exercise plan for these patients. And we want to instruct the patients to wear protective devices such as helmets and knee pads, elbow pads, when they decide to go bicycling or skating. Polycythemia is an excess of your red blood cells that are characterized by a hematocrit of higher than 55%. So, like I said, there are different types, but we're just going to focus on secondary. So, with secondary polycythemia, we have an increase in our number of red blood cells, and this happens in response to either excess erythropoietin secretion or prolonged hypoxia. So, with kidney disease um, or with an erythropoietin secreting tumor, so renal cell carcinoma, then we could get an excess of that secretion of erythropoietin, which would increase the number of our red blood cells. but then I want you to kind of like in your head think about why it would be that if we are in this state of chronic hypoxia, why we might develop polycythemia. So if you think about someone who maybe they are in a high altitude environment, maybe they just moved there recently, like Antonio, uh, maybe they have chronic lung disease, or if they're a smoker, or even chronic heart disease, but really we'll focus on those other three. So your body perceives that hypoxia related to whatever it is that is interfering with your lungs' ability to take in enough oxygen. So, as a response, they say, "Hey," your body will say, "Hey, let's make this a little better by giving us a little more in the way of red blood cells, so we can provide oxygen to these much needed areas." So, it's really kind of a compensatory mechanism that doesn't really work out. So, when we think about the manifestations, um, so hypertension, think about the fact that your blood is much thicker. So, let's say that your blood is the consistency of ketchup. And so now our heart has to try and pump ketchup through our blood vessels, through the smallest, teeniest, tiniest micro blood vessels that we have. And as a result, we get that hypertension because our blood or our heart is having to pump so much harder, and there's so much more pressure behind it that we become hypertensive. We have a headache, tinnitus, blurred vision. So again, this is related to the fact that your blood is so thick that it is affecting your eyes. Then we have that dark redness of the lips, feet, ears, fingernails, and mucous membranes, severe pruritus, and then extremity pain, weight loss and night sweats, GI bleeding, and intermittent claudication. So intermittent claudication, if you think about intermittent claudication, it is basically the same concept that happens in your heart during an MI, but instead it's happening in our lower extremities. So we're walking around because it's Black Friday and we're really excited about that super secret saver deal that we know about but no one else knows about. So we're running all around the store like crazy and our legs are going to need oxygen, but they're not getting the oxygen. So as a result, we have these horrible little experiences of pain because of that thickness in our blood. So we're going to diagnose this through high serum erythropoietin levels. We can do bone marrow studies that will show that our red stem cells are hyperplagic. And then also, I mean, you're going to recognize it whenever you look at your hematocrit and notice that the percentage is much higher than it should be. So that's going to prompt a more of a diagnosis phase at that point. Um, and then with treatment, we're going to focus on the cause. So if this is high elevation, one, we want to know, are they symptomatic? So what would symptomatic look like? Well, this person, if it's related to high elevation, would be hypoxic. So what are your symptoms of hypoxia? Uh, so just kind of think back to what we talked about in your fundamentals lab lecture. I might make you dig through your notes a little bit and find that one. But then if they are a smoker, then you're going to encourage them to quit. Good job, Tasha, trying to get Antonio to quit. That is a great way to go about it. And then there is a potential that they are going to need periodic phlebotomies. So this would be a removal of 300 to 500 mils of blood. And so if you guys go to ambulatory care, if you're at Floyd, that you will see patients that actually come in to have this done, usually about every like once a month or so. They'll come in and have this done. And then they also will be prescribed aspirin to control that thrombosis. So when you think about the management of care for this patient, it's very similar to the way that we're going to treat our sickle cell patients. So we're going to encourage them to rest until we get that extra um, blood off through the phlebotomy. We are going to make sure that they are hydrated as much as possible. Just different things like that. So just kind of look back at our sickle cell patient if you want to think about, like, as far as nursing interventions, what can you do in the meantime before. All right, so now we're talking about HIV. So when we talk about HIV, this is a retrovirus, so it replicates in a host cell by reverse transcription. So this is transmitted by direct contact with infected blood or body fluids, so the feces, semen, vaginal and cervical secretions, cerebrospinal fluid, breast milk, and saliva. First isolated in 1984, though I have read articles and listened to different radio reports where they talk about finding it as early as the 1950s in Africa. Uh, AIDS is that acquired immunodeficiency syndrome that goes along with HIV. So you can have HIV and not have AIDS, but there's no way to have AIDS without having HIV. It's the final stage of HIV. The progression to AIDS has slowed since we started the antiretroviral therapy. Without treatment, your HIV virus can progress to AIDS in about 10 years. With the antiretroviral treatment, a young HIV infected person can expect to live around 50 years. So we treat HIV more as like a chronic illness that you will treat with those antiviral drugs now, and you can live with HIV. So when we talk about the progression of to the point of AIDS, I would encourage you to look at the chart in your ATI book, which I'll put at the end of this slide, and we'll talk about what that looks like. And then when we think about the risk factors for HIV, so those needle stick injuries, especially in the healthcare setting, you can stick yourself with a needle. So you want to make sure that you know how to handle that. If you stick yourself, you're going to wash that injury out, and then you're also going to go to the emergency room, potentially start antiviral treatment. And then also, if you have someone coughing in your eyes or mouth, and then when you think about receiving blood products, there is a window period where someone could potentially donate, but not show up as HIV positive when they donate because it's still within that early window. Now, if you are actually going to donate blood, there's no risk that you're going to get HIV. So when we talk about the window period, this is what I was referring to when I was talking about someone who donates blood. If they donate before that window period, so that before the 6 weeks where those antibodies would be detectable, then it's possible that someone with HIV could donate blood and it would not show up when they test all of that blood. So when we talk about our high-risk populations, we think about African Americans, Hispanics, and then men who have sex with men, multiple sex partners. This is heterosexual or homosexual. So sex with those known to have HIV or at a high risk to be infected. Unprotected anal intercourse, perinatal exposure, injection, drug users, so sharing needles. And then worldwide, the most common mode of transmission is actually heterosexual intercourse. So if you think about what happened in Austin, Indiana, most of this predominantly was through the use of injection, drug use, and needle sharing. So we're going to teach our drug users, hey, listen, we get that sharing is caring, but make sure that you wash your needles out with bleach and then water before you share. So when we test these patients for HIV, they're going to have a HIV rapid antibody screening test, and then those immediate results will occur, but they have to have further testing to confirm. So they're going to have that ELISA or ELISA, this test for HIV antibodies. It doesn't detect the virus, and it may result in as a negative if the antibodies have not developed yet. So it's most effective 13 weeks after the infection. So even if this is positive, they still have to have further testing to confirm a diagnosis of HIV. So here is the final form when you are testing someone for HIV. This is the final test you're going to do. This is the Western blot antibody testing. It's more reliable, more time consuming, and more expensive than the ELISA, but it is definitely going to give you that definitive diagnosis. So this checks your HIV viral load, measures the amount of actively replicating HIV, and then evaluates your disease progression and your response to your antiretroviral therapy. So your initial HIV manifestations will kind of just, if you just look at these symptoms, kind of pops out as, oh, it's flu season. Probably just got a little bit of the flu. After you get over this flu cold-like feeling, you'll enter a prolonged asymptomatic period. So when we think about the opportunistic diseases, you think about the different neurocognitive disorders that may occur as a result of HIV that can disrupt your motive, cognitive, behavioral, or psychosocial functioning. You can have HIV-associated dementia, pneumocystis pneumonia. So the most common pneumonia affecting patients with AIDS is caused by pneumocystis jirovecii. And then tuberculosis. So TB is actually the leading cause of death among those with HIV. Then you also think about the herpes simplex virus. So this is what gives us those chronic ulcers. We have disseminated and extrapulmonary histoplasmosis. So these are parasitic infections. They can affect your CNS, lungs, or GI tract. Then we have Candida albicans infection. So this is that oral thrush, the white plaque on your buccal mucosa or tongue. This is an early indication of progression to AIDS. And then esophagitis, bacterial salmonella infections, which commonly will cause diarrhea for these patients. So Kaposi's sarcoma is a pretty big complication with AIDS. It's the tumor of the endothelial cells lining the small blood vessels. So they'll have lesions that affect their skin and their viscera. So you can look at that list of common places that you would see that. Then they can have lymphomas. So this is malignancies of their lymphoid tissue. They can have aggressive tumors that affect their CNS, bone marrow, GI tract, liver, skin, or mucous membranes, and cervical cancer. So your women need to get checked and have pap smears every 6 months if they have HIV. Just a quick discussion on the other associated diseases that can go along with your HIV. You have patients with cardiovascular disease as a result, and then also kind of just pointing out that there is a connection um, as high as 90% of patients with HIV will also have Hep B. Then also you want to think about nephropathy and wasting syndrome. So this is that weight loss. So a lot of people with HIV will have this involuntary weight loss. So they'll lose greater than 10 to 15% of their baseline weight. This is related to the diarrhea that they're experiencing, fever, chronic fatigue, and weakness. So you can look at your ATI book just for the list of antiviral therapies. Just know we're going to have a combination regimen of at least 3 or more of those antiretroviral therapy drugs. And then we're going to measure that effectiveness by measuring the viral load and the CD4 counts. And then also something you want to think about with that is how expensive is this going to be? Who's paying for this? I mean, when you think about your HIV patients, are they going to have money to pay for that? Probably not. So you've got to get them set up with some type of service. Can the local pharmacy fill it? Not usually. Now, I'm sure in Austin's case, that's probably something that's very easy to get filled now because there's so many patients that are going to need that. And then as far as nursing care, the thing that you want to think about is just we've got to educate these people. Look, hey, you believe in sharing because obviously that is caring when you share needles. But let's go ahead and just take some bleach and let's rinse that out, and then we'll rinse that out with water. I think I've talked about this twice now, so I just, hint, hint, wink, wink, nudge, nudge, poke, poke. Just kind of be looking for something about this. And then also you want to know who needs to be tested, and then what behaviors are considered high risk. Needle exchange programs, are they good or bad? I personally think they're probably a good thing. I mean, it gives us a connection and a chance to connect with someone that we might otherwise not be able to. Maybe we can pull them out of that addiction just through that connection. And then also we want to teach them about safe sex practices. And then if they're positive, no sharing razors, no tattoos. And then they're going to be obviously taking a lot of those antiretroviral therapy drugs, but we can actually use those to prevent HIV from an infected individual to a healthy partner. So the healthy partner would take them kind of prophylactically to protect themselves. So the trick to preventing your own exposure to HIV and to expose other people to HIV is to follow standard precautions with all patients. Report your needle stick injuries and dispose of sharps properly. If you do get exposed, don't freak out. I actually was exposed to HIV positive blood through a needle stick, took my entire retroviral therapy prophylactically. It does make you very sick, but I did not get to HIV. So that was a good experience for me because when it first happened, I thought for sure, oh, well, now I'm positive. It's cool. I've had a good life, but when you actually take a step back and stop being dramatic, it's actually not a big deal. You take your antivirals, and the chances of actually contracting HIV are actually really small. And then when you think about treating someone with AIDS, You want to consider, again, those opportunistic disorders and cancers. You want to assess their nutritional status. This person is having a really hard time eating. They don't usually eat high calorie foods and they don't eat high protein foods, so you want to push that on them. And then you also want to think about the electrolyte imbalances that will occur because they're not really wanting to eat or drink. That oral thrush can cause some issues with even wanting to eat. Same with the esophagitis, and then that severe diarrhea can get rid of the food that they do take in. So this person would probably benefit from soft foods because it wouldn't be so hard on their uh, esophagitis or oral thrush. And then they also might need something to stimulate their appetite. So for this, we give Megace or Marinol. And then also because this person is has such a nutritional imbalance, you're going to want to prevent further skin infections of lesions. And then if they're immobile, you want to just make sure you're relieving those areas of pressure, and you want to check their skin for dryness. Finally, the moment we've all been waiting for. Let's look at this HIV infection stages that you will find in your ATI book. So when we're thinking about staging, once we get to stage 3, this is where we are in that AIDS. So your clients that are in stage 2 or stage 3, obviously they're going to be a little more immune compromised. So when you get to staging and they get into that stage 2 to stage 3, you're going to want to start encouraging these patients, hey, it's not a good idea to go out in public because you're actually going to be putting yourself at such a risk to develop whatever is going around nowadays. So, like today, if we had a patient that was in that stage 2, stage 3 area, and they were like, hey, I'm really wanting to go to this Justin Bieber concert, you better not, because when you think about all the bugs that are going around right now, especially with this flu, it's just probably not a good idea, bud. Um, so maybe just catch Bieber some other time. But you just got to think about that stuff with these patients because they want to try to live as normal a life as possible, but sometimes if they are at a later stage, it's not going to be possible for them.